Hi everybody, you're in the VBID 101 presentation, and these glasses are your warning. This is one of your speakers, so if you're scared, you might want to go to one of the other presentations. Okay? I am Nancy Morris. I work for the Maine Health Management Coalition. I'm going to tell you about our work to develop a standard VBID plan in the state of Maine a little bit later on. But before I do that, we have the opportunity to share with you what's been going on at Eastern Maine Medical Center in regards to the implementation of a value-based insurance design plan at their organization. And so with us today, we have two gentlemen, Peter Close and Mike Donahue. And Peter is the Vice President for HR Operations and Rewards at Eastern Maine and is responsible for the employee benefits, compensation, retirement benefits, and HR Service Center. He's been with Eastern Maine for 2 years, 2.5 years, and prior to that he worked in the healthcare HR world in Washington, Baltimore, and New York City. And he will be joined with Mike Donahue. And Mike Donahue is the administrator, no wait a minute, he's got a better title than that, Vice President of Network Development and ACO Activities at Eastern Maine Healthcare. He's been there and growing the medical center's primary and specialty care practices, and he is brought with him an array of experiences and services to Eastern Maine and helped work in their pioneering work in accountable care organizations. It really has been a national model. I know something personal about Mike too, is years ago, here we go, now you know it's going to be good. Okay, so years ago I worked with Mike's wife, and nobody was more crazy about their spouse than Mike's wife was. So, you know Mike's got a big fan when he goes home, but I think when he gets finished today, you'll be a big fan of his too. So let's begin the presentation with finding out what's going on in Eastern Maine, and then after that, we will tell you what we're trying to do inside the Maine Health Management Coalition, and hopefully you'll join us.
Go for it. I will. I'm just going to basically frame this up a little bit for Mike. I'm going to talk a little bit about the history, the recent history of what we've been doing at EMHS with the employee benefit plan, and where we sort of been heading, and just sort of the recent stuff. So, in a nutshell, EMHS, as many of you know, is in Brewer. Have 8 hospitals at this point, 2 home care agencies, nursing homes, for-profits, helicopters. We have around 10,500 employees, 1.3 billion in revenue, and we're anticipating that we're just growing, and we're sort of building for growth. The employee medical plan is a high deductible plan, and this year we're going to be moving down to 2 options. We have 3 coverage tiers. We have an in-system, which is our preferred, directed around EMHS facilities and strategic partners, in network and out of network. And then we have around 15,000 covered lives, 86 million in anticipated claims, and of course we're self-funded. I'm only really going to be talking about the last few years. Up until recent, we're sort of going through a transformation right now. And we've really been sort of a federation of hospitals and organizations, and now we're sort of making that evolution into being into shared services. In 2007, the Bangor area hospitals came together with a traditional plan design and multiple options. Everybody else sort of had their own. In 2010, we moved into a high deductible plan with 3 options, and then in 2011, we added a 4th option, which was, we call it in-system rewards, and it was geared around directing our dollars, our employees, to our in-system facilities. In 2012, we made we went into and this was the year that I joined, we went into a partnership with Geisinger. And Geisinger is the big, huge rural hospital system down in Pennsylvania, very doctor-driven. And we went there because we wanted to we shared somewhat the same vision, and we also wanted to work on how we transform our care. And what we've been doing with our health plan is that we've been using that as sort of, if you will, the sandbox from which we've been working as we transform. So the relationship we went into was not what I was used to living down in Washington and Baltimore. Basically, we own EMHS owns the provider network. Two-tier. We insource through Beacon our population health and wellness interventions, and then we have an internal clinical review team, which actually is working to modify and customize the Geisinger medical management to meet the main population. Geisinger brings with it, they process the claims, they contract the ancillary providers in an out-of-state network that we use. They provide the medical management. But however, the long-range goal is that our medical directors will also be along with their medical directors in terms of doing the whole entire population. They provide the analytics. They also subcontract our health reimbursement account, behavioral health and pharmacy benefits manager administrators, and they provide the website, including the all-important provider directory. They've also, outside of the medical plan, they've been working with our physician practices on process improvement. So I'm just going to sort of end, I'm just going to end with this, is that, you know, the renewals. We had, prior to going to the high deductible, we were having about 12% renewals a year. It was a traditional plans, very expensive. 2011 was the first year, 2012, 0% premium holiday, but that's pretty standard. I mean, you always go into a high deductible plan conservatively. 2013, 5%, and we actually had a lot of high unexpected shock claims. And then last year we had 3%, and this year we were a bit stunned, and we came in at minus 4.5%. At the same time, we're making some changes to it, and I'll talk about that in a second. So in terms of just talking about savings to operations, you know, if you say there's an 8% trend as an average across, we probably saved around $69 million since 2009. On the other hand, about our employees, they weren't accepting. EMHS, there weren't very many high deductible plans out there in northern New England. In healthcare, there's not very much at all. They felt it was very expensive. They were concerned, and we needed to do something about it. We certainly had savings coming in, but from my perspective as administrating the plan, we needed to do something because this was really for our employees. So in 2015, we really, this year, we spent the year working through trying to refine what our plan is. So we're moving to a much simplified high deductible plan design with two options, not the four we had before, less restrictive and more affordable. When we set it up originally, that fourth plan we had, the in-system rewards plan, we had a lot of restrictions. So for example, if somebody really trying to get people to stay inside where our electronic medical records are, where our, you know, all our investments in trying to get good quality care, non-duplicative care, and all that. And we did it with and it was probably too restrictive. We needed to back off a little bit and let the incentives work. We're also making a change this year so that when a member uses an EMHS facility, everything is going to be at the in-system level. So say, for example, you have a radiographer coming from somebody who would be from our not-preferred network, and we would have that had been a hybrid bill, so that would have been an in-network, a higher cost. And it wasn't intuitive to employees. Employees couldn't understand that. So we made that as a change. We've also increased our facility discount. And this is the discount that we provide to our employees for using our own services. And before we had a whopping 5.5%. and now we're moving it up to 20%. And we want to see how it goes this year. My goal is I would like to see it go a little higher. We just keep looking at my data. But anyway, and so that's a major move. Also, for our lower paid employees, people who are earning $1403 or less, what we've done is we've created a supplemental HRA account. And of $600 for single and dependents plus would be $1,200. And what we spent a lot of time trying to figure out what we should put here. I, of course, wanted it to be a lot higher. The CFOs really liked the idea, but let's, you know. And where we ended up was that we wanted it to be something that was pegged to an economic measure, because we didn't want it to be something that was just stayed there and that was it for the next 10, 15 years. So we pegged it to 250% of the federal poverty level, and as that goes up, we will be increasing this as well. And if we can get it higher than 1403, we will try to do that. But again, we're putting a lot of changes this year, and you really want to see what happens to the plan before you really start making a lot of changes. We also, and then in 2012, I just wanted to mention, we added a zero copay program geared around generic drugs and certain supplies for chronic illnesses. And our idea here was that we really didn't want to get costs to be a barrier for people getting their services, getting their meds. So and we're in our second year of that, and it's been very, very successful. And I'm now going to turn it over to.
All right, thank you. Thank you. I just have a couple of slides here that kind of describe things you probably already know, but what this is showing, and I actually was able to get an update from 2012 to 2014. That upper line is what's happened to the worker contribution to the premium over the last, close to 15 years. So it's gone up 212%. So I think that's driving a lot of the changes that are occurring nationally and locally as well. This, and I've got another couple of slides. Basically, there's a changing environment. It's much more consumer driven. The marketplace is changing. You've got new players coming in, and you've got, surprise, surprise, declining reimbursements from a provider perspective. This one I thought was an extremely, and I wasn't able to get an update on this, but in 1 year between 2012 and 2013, the high deductible component of open enrollments went up from 12% to 39%. So much more focus and emphasis being placed on what the out-of-pocket is for employees. And I kind of put a little of this together just to kind of show you, do a little kind of a journey to where we are now, where historically employer-sponsored defined benefit plan. Going forward and in the future, there's high deductible health plans paired with tax advantages and health savings accounts, HSAs. Adults in that kind of a thing are much more likely than those in a traditional health plan to verify what's covered by their plan, to talk with providers about other options and costs, and then to check on the price before getting care. So you're getting much more involvement on the part of the patient and the employee. Historic, also talk to providers about generic drugs. I know internally the percentage of generic drugs used has gone from 50% to 85%. So certainly patients are much more keenly aware of the prices. And then I think a lot of them are also developing a healthcare expense budget. If you've got a $5,000 deductible or out of pocket, you're going to kind of develop a budget as to how you're going to plan to spend that. Insurance rates were used to be negotiated between the employee and the insurer. Now you can get insurance purchase on the private exchange, and the private exchanges could involve arrangements between employers, private exchange sponsors, this may be insurance companies or benefit management consulting companies. You've got other people entering the market here. I don't think it's the same market that it used to be. Whoop, one more. Historically, the insurer bore the risk for higher than expected utilization and costs. In the future, the providers are going to bear some or all risk associated with cost and utilization changes. A lot of that was talked about this morning in terms of risk. Self-funded employers are exposed to higher utilization costs, and what happens naturally is self-funded employers, usually the larger employers, will shift to employees and provider networks, shift the risk. Employees, historically, the employees bore no financial responsibility other than a higher out-of-pocket premium. Now, much more out-of-pocket on the employee. And a broad network of providers with, that's probably too strong a word, almost non-existent cost and quality metrics. Now, in the future, moving to more narrow networks, could be open networks, but limited to providers who can meet quality and cost metrics. So, that's kind of a little bit of a background. I won't spend too much time on this, but this is, Beacon Health was created in 2010 by EMHS, really as a vehicle for the Pioneer project. These are the EMHS members. The P indicates a Pioneer, and the C is commercial. So we've got a lot that are both Pioneer and commercial. So as you can see, particularly with the addition of Mercy, it's a statewide network. So, as I mentioned, Pioneer in 2012 was our first year. It was just basically the PPS hospitals, EMHS, Eastern Maine Medical Center, Inland Hospital, the Aroostook Medical Center, and we had a independent private practice, Three Rivers in Waterville. And that was the same on the commercial side. In 13, we added all of the critical access hospitals that were part of EMHS, plus other. We've got Spassville Family Docs, which is a FQHC, St. Joseph's, which is across town, Acadia, and we've also added some of the Central Maine Healthcare family. And in 14, we brought on Maine Coast and obviously Mercy, both into the Pioneer. So I already kind of talked about this. So this is Beacon Health kind of by the numbers. In 2012, we had about 9,400 covered lives, and that was really the Pioneer in our first year. In 13, that's gone up to 26,000. In 14, it went up to 60, and in 15, it'll be about 100,000 lives. Most of these lives, that includes our own employees. Most of these lives are in at-risk arrangements. And it also gives you a breakdown of, the primary care practices, the providers, the staffing, etc. So we were kind of lucky, and that's where the name Beacon came from, because we were a part of the Beacon grant, so we were able to kind of jumpstart the whole care management infrastructure in 2010, 11, and 12. So some of the results of the program that we've put into place. This shows you what's happened to the acute admission rates for EMHS employees. So it's gone from 66.6 down to 41.7, and it's been consistent each year. ED visits, same thing. Not quite as dramatic a decline, but still a decline nonetheless, down to about 190, which is a pretty good number on a statewide basis. Hospital admissions, the CFOs love us. This is on a per 1,000 basis, you've had a substantial drop there. Readmissions, huge drop between January. It was almost flat in January to April of 12, as well as 13, and then it dropped sharply as we kind of honed our care management process and our transition to a care process. So what's happening on a spend basis? Peter kind of alluded to it on an earlier slide, but As you can see, on a per employee per month, the national trend is going up, at a significant rate, between 5 and 12%, and our per employee per month cost is really remaining relatively stable and actually dropped in 2013. So the care coordination program is really what's driving a lot of these changes. We did spend a lot of time and effort to get NCQA certification for our case management structure. We're one of the few in the country that has this. It's not an insurance company. And it really was part of our overall strategy to really do what we need to do. We need to have a consistent measurement of what care management is and how it's done. And this provides that. It's also a lot of work, but it does provide that. So the care coordinators work with chronic disease, complex patients. They do education. They're also embedded. If the practice is large enough, we embed the care manager there. We also tie into as many community resources as we can possibly do. And it's very collaborative. We've got a population health group that meets as part of Beacon once a month, and it includes long-term care, SNF, as well as the Beacon, as well as community members and citizens that are consume the resource. The other piece, the transitions of care is really a key piece. We provide, there's a transition of care nurse at Mercy, Tamick, and Eastern Maine Medical Center. And their job is really, and Inland, sorry. And their job is really to do that transition. They're employed by Beacon, but they're embedded in the inpatient facility. And their job is to make sure that the transition from inpatient to outpatient occurs smoothly and everything is taken care of. We do a lot of high-risk chronic disease management. The data that we get identifies the high cost and multiple comorbidities. We do exacerbation management, self-management, telephonic and/or device monitoring. This piece here is starting to get much more of an important factor where you can actually have a device in the home that can monitor and let the care manager know what's happening. And very frequent follow-up. So what's happened in terms of chronic diseases? So in the past 5 years, the employees and spouses with 5 or more health risk conditions have decreased from 13 to 1.2%. So there was a huge emphasis on focusing on that population that had all 5 or more health risks. And even though Beacon wasn't around in 2008, in 2000 we did have a care manager embedded in some of the EMMC practices, and then we kind of transitioned into the Beacon grant, so we were able to put care managers in even earlier than Beacon was created in 2012. So basically what this shows is that an intensive care management model does not only drive down utilization, but it also improves quality, and almost importantly, getting to the triple aim, it reduces the overall spend for the population. So,
did that last one have attrition numbers in it? Or are we looking at the same population over the 4 years, or is there?
That's a good question. I have to get back to you.
Well, it's for your benefit.
Right. Yes.
Yeah, a question for Peter.
Yeah.
Peter, on your improving your discount from 5% to 20% in the EMHS facilities, what was your thinking behind that? To give people more flexibility, but an incentive to use your facilities?
Yeah, and also, when I got there, there had been a lot of town hall meetings, hospital blogs, and talk back and forth, and I sort of paid attention to it. I looked to see what were the issues that were really striking people, and that one was very key. And I also think that EMH, we're in a very expensive part of the world, And we were concerned that we had an in-system structure, but you might still be able to go to in-network, our sort of our mid-tier, and possibly even get a less expensive service. So it was trying to show our employees that we valued them, that we want them to go to our services. We wanted to, I think, first and foremost, for all the refinements that we did this year, was that we really didn't do anything that increased the cost, that all the improvements were geared towards the employee, and were geared towards employee acceptance.
One thing I should have pointed out, Peter talked about the in-system. So anybody that's a Beacon member is also considered, their PCPs are considered in-system. So St. Joseph's is, their PCPs are in-system, as well as any of our other Beacon affiliates.
Does the EMHS see the HSAs in the high deductible plan?
We are, no, and we don't use HSAs, we use HRAs.
And the HRAs are just for, it's just, are there two HRAs? One for everybody and then the supplemental for the lower
Correct.
incomes?
That's correct.
Yes.
Is the HRA funding included in your PEPM that you showed?
Yes,
And that was a PEPM, correct?
yes.
Yes. Got a question?
Can you tell me why you chose the HRA versus the HSA?
I wasn't there at the point, but essentially, a few reasons. One is our 340B program, and we needed to keep the co-pays out of it. Another one was that on an actuarial basis, it worked for us. And also, we were looking at the health plan as something that we want to continually refine and work with the plan design, and you have a lot more flexibility with an HRA over an HSA.
Have you had any impact to your own bad debt experience within your facilities
What a
associated with
great
employees?
question. That, when I came to Maine 2.5 years ago, I had not been in a high deductible world. And so I was a little taken aback by all of a sudden having a high deductible plan that I was sort of the steward of. And that was actually one of the very questions that I had. And yes, we have bad debt, but really what we had before, hospitals always have a way of dealing with people's costs. And so before, a lot of the hospitals didn't take any charges. If you came to us, we wouldn't pay for it or something. And the amount of money that we were spending for that basically transferred right into the bad debt coming from the new plan. So in some ways, you can say there really has not been an increase. Intuitively, I have problems with that. I mean, I had the numbers checked, but intuitively, you would expect that there would be an increase. But one of the things that we did this year was that, our premiums were already way, way below market. And with our 4 different plans, our primary ones were right at market for a high deductible, but the plans didn't necessarily make that much sense. And the most expensive one, actually, the one that didn't have any volatility, was still more expensive for your true employee risk. So we changed that this year. We actually, even though we're a high deductible plan, we brought down some of those deductibles. And took some other measures to make the plan more affordable. We didn't want to move away from the high deductible program. What we wanted to do was to impact on the employee risk. So one of the things that we're going to be doing, and we started off this year, especially with our partnership with Beacon, is that we're working on interventions we're working on our wellness incentives. And we will still have to have a cash, say for doing the health reimbursement account and stuff like that. When you have unions, you have some limitations. But what we're trying to do is to take the money that we were giving for our total health credit, but we really didn't have any teeth in it. And we're trying to move that over through the next 4 years so that what we're using it for is that if you're totally participating with us, you're working with us, that risk that you have between, you know, the deductibles and the maximum out of pockets gets lower. In other words, we're increasing. We're going to want to increase that HRA amount.
The chronic diseases that have the zero copay
Yep.
plan, were those based on employee feedback, or did you look at the numbers? How did you come up with those? I think there were 4 altogether.
They actually came from what EMHS felt as part of its vision for the areas that they looked at our community as a whole. It wasn't really directed at our employees. It was dealing with what are the chronic diseases that we as a system want to be working with. And so when I built the zero copay program, you know, of course I had to sell it. So I took what the physicians had already decided that they were very interested and focused in, and we grabbed onto that, and we did some other elements from other folks, and we worked it into the system. So these were already areas that we were focused on.
But either by chance or not, that's where a lot of the spend is.
Have you been able to move the needle on that at all? Or is it, do you have enough data to see whether or not you've been able to move the needle on that?
We've had a number of conversations with our pharmacy folks on that. It's our medical director. He might be able to help a little bit on this more than I can. But it's hard to say where in the medical that you've drawn down by what you've actually done by the pharmacy step.
I think some of the measures we measure. I forgot to ask the question. Oh, okay. So we're looking at a couple of measures. One of them is population segmentation. How many are moving from the moderate to the low or the risk, and that we saw a shift in that. We're looking at medication adherence, compliance, getting the prescription done, and we've seen an increase consistently over the last 2 years. There was more and more compliance and more purchase of the medication. Unfortunately, we're taking that from the pharmacy data, counting the pills, and the one element that we don't have is really from the EMR to see and verification that the patient is actually using, which I think everybody's challenged. But we're seeing the outcome in the segmentation similar to this.
Okay. Okay, actually, Julia, would you do me a favor? Would you keep the door open? Does everybody feel we need a little air? Okay, that's what I thought you might think. Okay. Thanks, Julia.
You're welcome.
Can we ask questions?
Yes, sure.
So Peter, on your talking about changing your plan design this year, now that out-of-pocket costs, are you doing anything with what are you doing with your premiums this year? Are you trying to offset?
We're dropping
No,
them.
you're dropping them.
But that's because what we did was we had such savings this year that we cut the savings across for both the organizations, our hospitals, as well as for the employees. So we took an equal savings on both.
Any other questions?
Can you go back to that slide? She's walking away with
Maybe.
Alright. So that's fine.
No.
One that says question?
The first 2 pie charts didn't have a moderate to high, the yellow slice, and then the second 2 years did. Did that get taken from the high population? Like, why wasn't there a moderate to high in the first 2 years? Did you add that category?
That was our analytic company. These numbers are provided to us by Geisinger Health Plan, and I think they have some historical data that got from the prior carrier and translate that. So they added the definition of moderate high to deploy care management strategy back in 2013 and early 2013, and so we did it moving forward. We haven't done the exercise of going backward and seeing, recalculating or redefining the population. So that's basically just taking the time to go back and do it.
Okay. Ready for an afternoon jolt? I'm your next speaker. I'm also introducing myself. We do things efficiently in the Maine Health Management Coalition. I'm Nancy Morris. I'm the Director of Communications and Member Services at the Maine Health Management Coalition. And I'm going to tell you a little bit about my background and why I'm working on value-based insurance design. I went to school to be a disc jockey. While I was there, I became a television reporter for NBC, and the television reporter from the person who was in charge of the newsroom said, when you leave here, I have 2 job offers for you. You can either continue to be a reporter here, or you can start a singing telegram company. So I was 21 years old, I knew it all, and I said, well, I could always come back to NBC. No one's ever going to ask me to run a singing telegram company again. So I ran a small business. I ran a singing telegram company. It was fun, and we had it was successful, and I learned a little bit about owning a business and running a business. So then from there, I started to hear about HMOs, and I actually came to 3 locations to start up an HMO, and the last one was here in Maine, and I came to start HealthSource with Skip White, and I worked for many years with HealthSource. And then after I decided it was time for me to leave HealthSource, I started working with doctors and hospitals up north on quality improvement. And so I'm no good at anything, but I do have some sensitivity to what it's like to be an employer, some sensitivity about what it's like to work inside an insurance plan and what the requirements are to make that run smoothly. And I also understand a little bit about what it's like to be a provider. And so when we were asked to put together a new kind of health plan for the state of Maine, I tried to draw on all the complaints I heard through the years and try and see if we could try and come up with a different way of offering benefit plans. And one of the things that seemed very appropriate was a value-based insurance design, because quite frankly, not all services are created equal. There are some services where we have a preponderance of evidence that those are the right things to do if we want to help a patient have a better outcome in either terms of their life and their health, or in preventing further services down the line. And those are what's known as effective or evidence-based care. Preference-sensitive services are also evidence-based, but does anybody know the difference between those two? A preference-sensitive service means that there's more than one way, that the evidence shows there's more than one way to get to that goal. And so many people don't, when they go to a doctor's visit, don't learn about the 4 or 5 options they may have. Many times they're just given one, and we think under this plan we need to expand that a little bit. And the last set of services are called supply-sensitive services, because in many cases there's less evidence about those services, and they tend to be influenced by the supply of those services as opposed to the evidence suggesting that they be done. So why did we start to design a value-based insurance program in the Maine Health Management Coalition? You know, our job is not to be an insurance carrier. We still don't want to be an insurance carrier, but why are we starting to work on a plan design? I can tell you it's not because we're not doing other things. I promise you, we got other things going on. It was because when we pulled together, with the help of Angus King, CEOs in the state of Maine from businesses and from hospitals, they came back and said, you got to develop a plan that puts us on the same page, because right now we're not on the same page. The way we reimburse providers doesn't make sense. We're paying the most for the most intensive services that many times could have been avoided and we didn't want to get to. And the providers were telling us, do you have any idea how crazy it is to operate with 60 different rules for just one insurance company, because they have 60 different plans? That complicates things. You can't, you know, that's quality improvement 101, is to be able to standardize to get to quality. And oftentimes they said, as you're building these plans, you're taking away the benefits that people need to get the better outcomes through your plan design, and it's not making sense. So please come back with a plan that makes sense for all of us. So when we had the opportunity to respond to the federal government's request for information and ultimately a proposal to build a new way of providing services in the state of Maine through the State Innovation Model Award, we built into this the idea that we would do a value-based insurance design template that we share, give away, anybody can have, no matter where you're from, not even Maine, and yet at the same time build in these goals of reducing the total cost of care, improving the health of the Maine's population, improving patients' experience with care, and increase the number of practices who give out more information and specifically patient experience. So here's what we came up with. And everybody has a copy of this. Hopefully, if you don't, raise your hand, Robin will get you one. Oops, we got a few. Okay. And if you look at it, the arrows are there because it's somewhat of a fishbone diagram. And we try to, as we develop this, you know, because I don't feel like I'm that bright, I always read to see what other people have done and see what the evidence says to kind of guide us. And when we started to look into value-based insurance design plans, we saw that there were some savings that come over time, but that they can get swallowed up by other things. And so that's why you see these arrows kind of going through, is because we said, well, we can't really do this in a vacuum. We have to go broader if we're going to be successful in lowering costs overall and making sense for things for patients. So the first part of this plan starts with the benefit package, as most benefit plans do. And here's what we did. We made believe we were in Atlanta. Isn't Atlanta where the place where they have the green light top? So it's a very big Irish community, and they switched it up. We'll probably having accidents as we speak, but that's how their stoplight works. And so we said, look, right from the start, we thought, how are we going to communicate this to patients? The healthcare system's too complex for patients. They want to engage. We do a lot of focus group studies to develop the Get Better Maine website, and we've heard over and over again from people is when we go for healthcare services, we think we're overserved, but we don't know which service is too much. It's sort of the Goldilocks syndrome. They don't know, they know something's amiss, they just don't know what's amiss. So we thought it would be very important to start to help patients know what's effective care, what are the services that are preference sensitive, where you have some choice, and what are the services that have the least amount of evidence. And so we thought we'll build it so we can also help the clinicians, because we know that paying for services is not enough. You know, we know under the Accountable Care Act, they're going to pay for preventive services. That doesn't mean your brother, who's a pain in the neck, is still going to go in and get a colonoscopy at age 50. Just because it's covered doesn't mean they're going to go. So we thought we've got to start from the beginning, giving tools to the providers and messaging to patients and hitting people on the head, and giving messaging to patients to help them understand this is really important. A green service, you should go. Don't question it. Do not pass go. Just go, go, go. And so we wanted to let people know when they were getting services, what was the cost and the efficacy of those services. So we decided to follow this framework. And what we're hoping to do is to reduce some of these unnecessary services. And we'll show you in a few minutes how we would do that. So let's say you went into the doctor and the doctor ordered you a green service. What we think is important that patients know at the time of service is how effective this could be. So if you get epinephrine with or without steroids for bronchitis, your chances of 1 in 17 are being helped. You have a chance of preventing a hospitalization. And there's no harm, there's no side effects of that. So you want to do it? You know, as a doctor, you now have a little help to get patients to do the right thing by having these services color-coded. And because EMRs are built nowadays, in many cases, to also do billing, it's not much more work to share that information at the time of service with a patient to tell them how that's going to be covered under their insurance plan. And we still haven't come up with the specifics on this, but that could potentially be a fully covered service, a green service. Go get it. It's good for you. The evidence is on your side. Let's go. Okay. Now the next thing is a yellow service. And a yellow service is one of those services when there's more than one option. And those services could be equally effective or very close in effectiveness, but they have pros and cons. And so go back to your brother who's not going to go get that colonoscopy. I'm not taking that joke the night before. They're going to rip me up, and I know this. I'm not going in and getting that. Wouldn't it be nice for them to know that there's a test you can take at home and get that service instead? And if he knew that, might he do that? And so we think if patients know what their choices are, that A, they're going to maybe find something like Goldilocks that fits, but also two, is if that doesn't work for them, they know that there may be something else. And so instead of letting a problem, living with a problem that could potentially be helped, they're going to start to learn that there could be another way to take care of that problem. And so this, by the way, is open source. This is from the Mayo Clinic, and these are some of the tools that they use to help patients pick out prescription drugs for them, and it even includes cost. So I'm just giving you some illustrations of what it could potentially look like. Now let's say it's time for a red service. This is where we're thinking potentially a deductible might come in handy, because we know high deductible plans help patients curb their use of services. The problem is we know that it also curbs the use of services we want them to get. And so we thought by color coding and letting them know that, reinforcing that green service is covered, that yellow service is covered if you just slow down and look at your options and pick the best one for you. The red service is when you want to use your doctor's help. And so let's say now, you know, the patient said, well, I'm all good about heart disease. I take an aspirin every day. Well, now we can, the patient can also get some sense of how helpful that is. And the doctor could also say, and by the way, look what's even more helpful. Just change your diet. Eat more fruits and vegetables. Eat more fish, less sugar, healthy fats. That's actually more effective, and so let's talk about how you can get there. So this is what we want to start to help patients, and again, tell them at the time of service how much it costs. And for those of you who work in a practice who are afraid to collect money at the time of service, I just want to tell you that we collect money all the rest of the day. You know, I mean, I have a more long-term relationship with my hairdresser than I do with my doctor. I know more about my hairdresser than I know about my doctor. And I don't think that our relationship is harmed if when I get finished getting my hair cut, that I pay her right then and there. And, you know, wouldn't it be nice if we told people at the time of service, before they got it, like we do with other services, how much it's going to cost. We could vary this up for their particular benefit plan and tell them, and then when they go out to the front desk, pay. I told you before, I spent 20 years working in an HMO. When a bill comes home to my house, I get it better than most, and I put it aside. Because the first one isn't even a bill. All right, right? The second, right? So you get that one, my husband pays that one. Okay, he pays the EOB. So he sends the whole amount of money because you think this happens, if it happens in my house, I know it happens in other places. So my husband pays the EOB, okay? So now I have a credit at the office. They end up paying me back later on. And meanwhile, when the bill comes in, I am like, oh, I don't know if they, blah, 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 I don't want to deal with that now. So then they have to send me another thing. And I offered to pay up front in the office. And so many times, oh, no, we don't deal with that now. And it's okay. It's okay. It's okay. It's okay. We pay for other things. If we could tell people at the time of service what it was going to cost, it's not going to be a surprise. And you're not going to have bad debt afterwards as much. I'm not saying this takes care of everything. But if patients knew up front, they'd say, well, maybe I don't want that. And when I rolled this out and showed to some doctors, one doctor said to me, "Oh my gosh, Nancy, this is what I've always wanted to be, a help desk." Means that I can now start to tell people, you know, here's the efficacy of this, here's your options, and you know what? Now you're at a red level. Now it might really cost you some money. So let's see if it makes sense for you. And I will tell you, again, my goal is to help sell this plan and help people feel good about it. I think most patients would think this was pretty helpful to have this information at the time of service. So now let's look at the second piece of the equation. So now let's say we've got a good handle on the benefits. And by the way, there are the medical directors of the health plans in Maine and several other people that I'll tell you about later are working with us to decide what buckets each of these services go through. We're going through every single code, okay, and deciding which bucket it goes in. And we're even making changes along the way. For instance, in colon cancer screening, we know the options for colon cancer cost either $15 or sometimes up to $1,500. First of all, patients don't usually know all their options. And the second thing is if the patient picks that very inexpensive service and it turns out to be positive, then they're now on the line for the $1,500 bill. And so what most doctors will do is help out their patient. And that's what we've been thinking all the way through is we're not talking about spy versus pie, for those of you who remember Mad Magazine. We're talking about somebody who's trying to help somebody else. So a doctor isn't going to order a colonoscopy because they don't want that person to have an impediment to getting that service, so they just bypass it. But we've changed up the benefit plan through the VBID work group to say we'll pay for a fit test because we think more people will go for that. Only a third of people who are ordered a colonoscopy even go in it and even get it, even though for men between 60 and 64, it's a home run in the bottom of the ninth in the World Series. And it really can save a lot of money and a lot of heartache for a family, and yet a lot of people don't get them. So if they knew more options, they would take it. So we set, the VBID committee agreed to say, okay, we'll pay for that inexpensive fit test that's easy to take at home, you don't have to take a day off, etc. But if that's positive, they can move on and have that colonoscopy. And if we find polyps, that's good. We've helped somebody, so we're not going to charge them for that either. And so they've started to look at the benefits from the point of view of the patient to say, why wouldn't the patient go along with this? Or why would somebody just move to one of those options? It's because they're trying to help people. So we're trying to make sure the plan is designed to help people. And you'll see, for those of you who are clinicians, we're going to help you too, I hope. So the next piece of this is who provides the services. The RAND Corporation taught us years ago that it's important to go get services, but you don't always get the care that experts recommend when you go to the doctor. So we think it's very important that we make sure that patients get to a doctor who provides the care that experts recommend. But we also think it's important that we now have the data inside the Maine Health Management Coalition to tell us who's the most efficient providers too. So we're going to look and prefer the doctors who are both effective and efficient. And if we don't have any in our network who are effective and efficient, then the next choice down will be effective and inefficient, with the hopes that we can get there. Okay, so that's what we're trying to do, is because, you know, we've talked a little bit today sometimes about the cost of health care, and everybody who works with me knows I say this all the time. Health care, if it costs a penny, if you get it down to a penny and it's not good health care, that's not a buy at all. It's got to be good, high quality services, and we want to make sure that that's how we're going to get value out of the health plan program. So the next thing is, okay, now how do we redesign this payment? We need to redesign the payment so it becomes based, because that's what we want. We don't want, I mean, maybe you do. Maybe you have some kind of mental problem that makes you want to have all, I mean, because we all know there's Munchausen syndrome where you want to get sick. So most people don't want to get sick. They don't want full coverage for stage 4 cancer. They don't want to get that. They want to be healthy. And so we want to make sure that what we're incentivizing is to get the care that experts recommend intensively on a primary care level to arrest conditions as soon as possible. And Eastern Maine Medical Center, in fact, and so did Intermed, did a great job of reducing hospital admissions by really beefing up the care that they gave patients. And Mike talked a little bit about having more than just a doctor in the office, but support people who can help motivate patients, who can direct them to services in the community, and to work with them to get to arrest their condition at the earliest stage possible so that they can get better care. And so we need to change up the way we pay those providers so that they can survive on this, because they're going to need to spend more time helping patients at an earlier stage. And so what we're recommending is that potentially the doctors could get a share in the gain. So if we look at their historical spend and they save us 30%, they get a slice of that. But I can tell you, we think everybody who's been involved has to get a slice of that. The health plan who'll help facilitate it, the payer who'll help pay for that, as well as the patient. It's got to trickle down to everybody, because everybody has to be part of this to work. So now we've gotten all these things in place. And how can it fall apart? A patient who walks out of the office and disregards everything that was been said. So why do we care? We gave them the care the experts recommended. The person was like this the whole time. What good did that do? So we thought that, gee, we've got to get some supports in place to make sure that when patients are go out into the community or back to their workplace, if they happen to work, is that there are supports in the community to help them follow the care that experts recommend, because a lot of time with chronic illness, it's self-management. It's their diet, it's their exercise, it's taking the meds, and we need some kind of support. So we felt like if anybody offered this, we wanted to make sure. And if you flip over that chart, you'll see why we recommended some of these things. Because this is a study from the IOM, the Institute of Medicine, to show that if we institute some of these things, we could have some real potential savings. One other place where we think we can have some real potential savings is on administrative. And the other reason why we want to slim down the administrative work is because we want clinicians to want this plan. And one thing that I've heard from clinicians through the years is, oh my God, the paperwork. And we need to take care of this paperwork, not just because it's an expense, which, by the way, Health Affairs pegs at $86,000 per doctor in each practice each year. So if you have 10 doctors, take $86,000 and times it by 10. And that's the cost of administrative paperwork to get reimbursed. I've seen figures that say 10% of your hospital bill is to get reimbursed. And one thing we've learned through the years is that other countries are able to do better in outcomes because their administrative requirements are standardized. Could you imagine being behind somebody at the grocery store who was paying in yen, and the person in front of them was paying in francs, and the person in front of them was paying in pesos? Would you get on that line? And yet, in an office practice, the rules on those practices and the rules that hospitals have to deal with, they're changing with each and every patient almost. The drugs they can use, the pre-cert recommendations. And so we thought, could we start to look at this? Could we start to credential doctors once in the state of Maine and use it for everybody? Yeah. So you know, we think there's some money there, and that can go back to the practices, and we can start to keep doctors who want to practice. This is a big reason why doctors are sick of practicing. They feel like they're spending so much time on administration that they can't spend the time they want with patients, and they can't do the kinds of things that we know are great for the patient. So we really want to take a look at this. And then we want to adjust the plan design so it makes sense for everybody. So again, a doctor doesn't have to go right to that colonoscopy because they're worried that the person's going to get a big bill later on. Okay, so right now, we are lucky that every single major health plan, Anthem, Aetna, Cigna, Community Health Options, Harvard Pilgrim Health Plan, and Geisinger, who's the TPA for Eastern Maine, is working with us to try and figure out what can we do to standardize administration, what can we do so that we can develop a single plan design. This is not designed to replace everything. We're not saying we're turning communist and one size fits all. What we are saying is what we want to do is have a single plan design that could be made available. And so if you're an employer, you could go and say, I want the VBID plan that everybody worked on, and you would be able to get a ranking on how good that health plan worked. And if you're a clinician, you could eventually say, look, I take all health plans, I take all carriers, but I only take the VBID plan, because then they know everybody who comes in has the same rules and the same benefit package, and they'll be able to have this information when they go through. Okay, so right now we're in the process, I'm going to go back for a minute. Right now we're in the process of developing this. We have 3 hard-working subgroups. The first is the medical group, and they're color-coding those services and looking at how the benefits are set up to make sure that they make sense. The second group is looking at administration, and again, I gotta do a shout out to the health plan because many of them came to the table with a list of the top 10 complaints from their patients and providers to start digging down and seeing what's a problem and how could they standardize it. And then the third group is working on the wellness incentives or disincentives that need to be in place so that we can help patients do the right thing when they leave the doctor's office and get more value out of their benefits. And so once we develop the health plan, which we expect we'll have done by this time next year, what we're going to do at that time is start to publish information. Right now, what we'll be doing is just publishing information about the work that the health plans are doing with us. And what we're asking them to do, and you've heard some of these things in some of the presenters before, start to standardize the plan design and the administration of the plan design. Start to have one set of quality metrics so that we can save the money and the confusion that exists by having multiple standard quality metrics, and then work to standardize the administration. Again, if we didn't learn anything from having a book club 2 years ago, we didn't learn anything if we didn't understand that standardization is a way for us to get better health care at lower costs. And then as we move along and we pick out the things that are key, people will be able to go to our website and get that information. So why should we work together? Well, first of all, I think we have a couple of things that we didn't have years ago. First of all, the Maine Health Management Coalition, which for those of you who don't know us, we're a not-for-profit organization. We have a very robust claims data set now. The insurance carriers give us information for their members of the Maine Health Management Coalition, but we also supplement it with the Maine Health Data Organization, which is which is an entity that has the ability by law to collect in all the data from all the commercial payers. Then we have Medicare data and as a qualified entity, and then we have Medicaid data. So we can start to put the whole picture back together for the practice and for the state. And that is a huge thing to help us if we want to start to serve as a neutral arbitrator on these agreements. So how do we know that you've saved money over last year? What goes in, what goes out? What data set do we use? We believe in our data set and you believe in your data set, but we both believe in the Maine Health Management Coalition's data set, so let's use that as a natural arbitrator. And we believe that standardization is the foundation of quality improvement. It is very difficult to get the outcome that you want, that we want as patients, if the rules are changing with every patient. And so if we can start to standardize that, we think that we can do a better job. And certainly we can do a better job with quality measurement, because there is a lot of time spent on that we could slim down and make more information more transparent to patients if we started to say, what are the key ones, and we're going to collect those, and everybody's going to use this. And by the way, we're working, Medicaid is also on the team trying to standardize things. And even though Medicaid can't say to somebody, you have to pay more for this service because it's less work, we believe that if clinicians are used to saying, this is a green service, this is a yellow service where you have options, and this is a red service, we think Medicaid beneficiaries want to know that and should know that too. That you're about to undergo a service that we don't have a lot of evidence about. And so we think that that will be and should be information. We also think that if we do this together, we're more attractive to the organizations that we need to help us do this, like electronic medical record vendors, like grantors, and like government payers, because Medicare is very interested in looking at value-based insurance design. They just released a request for information. It's due back on November 3rd. And I think if they find out we're trying to standardize things with other people, we already have started on this way, that it's a good use of their efforts to join us, because we already proven we've gotten so far. And so that we can start to standardize things, and the more we work together, the better off we'll be. And we also will have an opportunity, I believe, to attract and maintain more primary care physicians. If anybody's read anything about the Accountable Care Act, what have you seen in the literature? We don't have enough doctors to give these benefits out, right? You've seen that in all the literature. I think if we start to make it more normal, less complex to deliver health care in Maine, that we will be able to maintain more primary care physicians here in the state of Maine. And I also think another thing that we would get out of this is to be more prepared for a crisis. How lucky we are that we don't have Ebola here. How lucky we are that we've never been hit by Hurricane Sandy or the other things that have happened. But if we can start to standardize, if we can start to pick the best practice and start to implement that, our clinicians are going to be more efficient and effective, and if we have a crisis, they can take care of more of us. And so that investment right now, I believe, if anything bad happens later, will come back to us. So I just want to do a shout out. I know I'm old, but I could do a shout out. And so, just for the organizations who have been doing and working with us, it is a little bit crazy to do this, you know, and we don't have any authority to do it. People are coming voluntarily, but they're coming, and they're all bringing an amazing piece to the pie. And we've all seen that graphic where everybody's looking at an elephant and seeing different things. I can tell you, having more people in the room with more vantage points is making the product better. And everybody is contributing. And it's interesting, everybody's perspective is adding another layer, and it's making more and more sense for patients. And we're attracting people from outside the state who are very interested, who see this program as a platform to get out some of the things that they are working on. And again, it's really been amazing. And I just want to point out too, I don't know if everybody remembers who Brian Atchison is, but he used to run the Bureau of Insurance in Maine. He's come back to Maine. He's so interested, he's so proud that we could be doing this. He understands how transformative this could be for the state. And so he's volunteered. He comes in from Washington, D.C. to be part of the committee. So, and again, there are plenty of other national and advocacy groups who are putting there. And if you thought Neil Shaw was cute before, he's on some of the committees. So anyway, okay, so let's see if we can get this to work. Okay, I gotta get to this. Sorry, nope, sorry.
I blew it? Oof.
Yeah.
You need it, it's back, it's back. Or you can copy and paste
No, actually it's Blake's. Okay, but you're gonna see a commercial for a minute, but I understand I'm crazy.
If you've learned a lot about leadership and making a movement, then let's watch a movement happen start to finish in under 3 minutes and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore, it's about them, plural. Notice how he's calling to his friends to join in. So it takes guts to be a first follower. You stand out, you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut and it's not two nuts. 3 is a crowd and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see followers because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point, and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute, you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public. Be easy to follow. But the biggest lesson here, did you catch it? Leadership is overglorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.
So, that's how I just want to tell you, it's a little crazy. It's not been done anywhere else before. Maybe it shouldn't be done here. Maybe we don't have, but I think we do have people who could work together. That is one of the great things about us. That's one of the reasons why the gentleman this morning came all the way across the country, is because he's so impressed with the ability of people in Maine to band together to do great things. And so we just want you to know that you're invited to join the VBID groups, one of them, all of them. But we think having more people in there would be very helpful. We think the more people who are in there can help make this plan even better. And one thing I want to just particularly point out, for those of you who work in health plans or offices, clinical offices, you have people, I know you do, I feel it in my gut, have people who could tell me tomorrow 14 things that we could do to reduce healthcare administrative costs, and that could make so much of an impact, make it life easier for all of us as patients and in our business day. If you know one of those people, I want to see them, and I want them to join us, because I think they can have a big impact. And please feel free to join us. When we get finished with this value-based insurance plan, it's going to be available to the whole country. So anybody can pick it up. We hope the health plans in Maine will offer this health plan. Doesn't mean you have to take it, doesn't mean the only thing they're going to sell, but we want to make it available, because we're hoping that as we start to do some of these things, like reduce the need for multiple credentialing, etc., it will be out there in the public, and if people want to pick it up and do it across the board, they're going to be invited to do so. So thanks for coming, and if you'd like, please see Robin Allen. Behind me, as everybody knows, is smart people. I'm sort of the crazy dancer, but there's plenty of smart people behind me, and in this case, it's Robin Allen who works on the VBID plan, and she is helping make this happen, and so see Robin if you'd like to be involved. Yes?
Well, I've always known you're great.
I know. No one.
I have two questions.
Sure.
About the model you put together. I think there's been some contradictory analysis of patient-centered medical homes, or at least some analysis that suggests that the touted value may not exist. I'd love to hear your comment on that. And my second question is, and I noticed no mention of any of the rapidly growing retail approaches to primary care.
Okay, well, two things is, if you want to answer this, there are some experts in the patient-centered medical home model here in the room from Quality Counts, and I can have them talk to you about this. I agree, there's been contradictory information. We do know, however, that patient-centered medical home practices can be very effective for a patient who has a lot of chronic illness and who hasn't been successful in the past. And one of the reasons why we asked those two gentlemen from Intermed to come is because that's a potential another way you could handle that, is that you could potentially have, sort of specialists in high-risk patients take care of a patient for a while. And we're going to continue to look at, by being informed by the whole group, what is the best way to go. As far as the retail operations, I too have read that there's a growth in that. I do think that perhaps a practice who knows, because of the new payment model, that they have some more flexibility on how they set themselves up, may want to have an arrangement where that could be their coverage group, or maybe handle patients who have small problems that could be handled by them. We're trying to go through each and every process in an informed manner by seeing it in each way. So there could be spots where people would use that, there would be spots where they may not use that, but that's why we're letting the group design this, so that we get more buy-in and we get more information from people who do this work day by day.
Since you pointed out, Nancy, thanks, I can follow up with some of the questions about the PCMH model. I think one of the things that we're talking about is how long they've been studied, because it takes a long time for transformation in the delivery system to occur. So that was some of the early. There was a JAMA article that came out, and it was studying only 2 or 3 years, I think. So, but I can certainly follow up with you. It's Judd, right? Yeah.
Yes. And thank you for asking that, and thank you for jolting my memory to tell you that this presentation has been taped. I probably walked out of the camera 80 times, and you probably never see me, but this has been taped, so if you want to use it to explain what we're doing to other people, you can. All the slides that we use today will be on the Get Better, not the Get Better Maine, the Maine Health Management Coalition website. So that's www.mehmc.org, and you can go there and get the slide decks if you want it for any of the presentations that happened today. And I'll work with Lisa to get you the information on the patient-centered medical homes, and that will be on there too. Okay? Anything else? Any thoughts? And just so you know, Judd, there's a doctor at Columbia University who's all about the evidence and, rating the evidence as how robust it is and so on and so forth. And I said, well, this is what we want to do. We saw what you have and we'd like to use it. Now, first of all, I'm going to go over the idea, and can you tell me if it's crazy? And so he said, it's definitely crazy. And I said, well, where's your evidence? And he goes, okay, you got me on that. I said, well, actually, actually, there are maybe some other people who can inform, at least through an observational study, that may be true. So it's like you're a doctor too. So anyway, okay, any other questions? Thank you for coming, and please,